It's time for Penguin Speaks.
Hey everybody, Penguin here. Well, I've been through the emotions of the doctor's visit for my wife yesterday, and I just want to kind of elaborate on a few things because I really didn't go into detail about her pain level and why she actually needs the medication she's on. I did mention about her having a shunt, and basically what the problem is with that is it's for the pseudotumor cerebra. That's the name of the disease. And basically, what that is increased spinal fluid, which causes pressure in the brain, which causes severe headaches, as well as the lower lumbar area, which causes pressure on the nerves and things like that. And this is one of the reasons why she needs pain medication. She already has a shunt. The first one was located here, which tapped into the meninges and everything to drain the spinal fluid because she was having spinal taps like once every 2 weeks. And if anybody's undergone a spinal tap, it's a very painful procedure. And then afterwards, you have to lay on your back for, I think it's 24 to 48 hours without getting up or as little as possible. I mean, you have to use the restroom and things like that. But that's one of the things that's going on. Well, she had that replaced twice, so she had to have 3 surgeries on her head. And then the last one, the doctor who did it was who did the first one, and she contracted staph infection from, I apologize, it was the second time she had it done, and she contracted staph infection when he did it, and she's still battling with that. We're talking about IV antibiotics, I mean real potent ones that makes her sick. It's just not really good, but she does it at home, so that's one good thing. But they put it in her back. It's called a lumbar shunt. Now that one is not adjustable at all, whereas the ones in her head, they were adjustable. They could put a magnet up there and turn it a certain way and open or close the shunt depending on the pressures and how it feels. Because not having enough fluid is as bad as having too much fluid as far as the pain that it causes. Now, both of these shunts drain into the stomach, and it just gets absorbed and excreted out through the science of that. That's a whole nother thing. So they're drained down. Actually, I said stomach. They're drained into the abdomen area. So that is where the fluid ends up, and it's not a whole lot at a time. If you think about it, your spinal cord fluid, your meninges, and everything like that, there's not a whole lot of fluid to begin with. I mean, there's a certain amount, and it's kind of not even really a trickle. It's just a small amount. I want to throw this out there concerning my speech today. It's a little bit slow, and it's not from being like over medicated or anything like that, but it's really from being overtired. I didn't sleep well last night due to the, I don't want to use the word anxiety, but just being upset about the whole doctor's visit, seeing her upset, things like that. You know, her being upset upsets me, and I just have to deal with that. So I'm extremely tired today, and I'm not having a great day as far as, post-stroke. You just have bad days where you're tighter, you're weaker than normal, and I'm having one of those days. They don't happen as often as they used to, but they still do happen. But I just wanted to throw that in there before anybody questioned anything about my medication, because I'm going to go into detail some of the medication that I take. And for those of you who have the knowledge may think that, that is a lot of medication. That's why he's being like this. But it's not, because if you watch my other videos, you see me speaking normally, where today is just a little bit slower. And it's really harder for me to get the words that I want to say, because as I'm talking to you today, none of it's scripted. It's just straight from the brain and from the heart, from the brain that could be dangerous. So I just wanted to throw that out there. So they put it in her back, and that one is not adjustable. Problem is, again, I said we moved to Georgia to be closer to her doctor. Well, unfortunately, she can't find anybody here that does work on lumbar shunts. So she's kind of stuck with it until she finds somebody to remove it and probably put it back in her head, maybe on the other side, because it's not working and she's having that increased pressure again. And it's only been the last visit where they referred her to a neurosurgeon to even look at it, because everybody knows with insurance you can't just go to a specialist. You have to have a referral. And that's, I understood, but that was never even discussed until this last visit after a couple of years. So it's causing a lot of pain. And unfortunately, it's something that, Tylenol, ibuprofen, it doesn't touch it. You need, heavy duty narcotics in order to touch it. She's taken things like morphine. That didn't work. She's taken Dilaudid, and that worked a little bit. And she's on the heavy duty C2s. So that doesn't work by itself. It's in conjunction with the other medications that actually subsides the pain and allows her to sleep if she wants to, and allows her to be functional as a human and do things that people do. There are times that if she runs out of a medication or whatever, she'll be in bed for a week or more because she just can't do anything because of the pain. And we're trying to get to the root of things and get things fixed. I'm going to get to giving the names of the clinic and the doctors as well, because it needs to get out there. I understand that maybe all of Georgia changing these rules, but my doctor doesn't seem affected by these rules because I'm still getting the medication that might be considered too much for some people, but it's what I need to function. And my doctor even said that you're a special case because of my tolerance for medication. I take baclofen as a muscle relaxer, and the main highest dose they want to give is 20 milligrams 3 times a day. Well, I'm on 40 3 times a day. And at first he was reluctant to give me that because he doesn't know me yet. So he did it for a month, and I went back and he saw that I'm functioning perfectly well. So he wrote the scripts for it. That's a done deal. The same with a drug called oxcarbazepine, which is close to Tegretol or carbamazepine. It's really for seizures, but it helps with the muscle spasms. Well, I was taking 150 milligrams 3 times a day. Well, then he increased it to 300 milligrams twice a day. And now I'm taking 600 milligrams twice a day. So I went from basically taking 450 milligrams a day to 1,200 a day, which is the high end of the spectrum for that medication. And my other pain medicine and everything, it's the same thing. It's high doses, but he didn't seem to have any issue with doing it. So for her, I think the practice, the nurse practitioner that she's seeing that's having an issue. And the thing is she can't even write for the C2 medication. When I say C2, for those of you who don't understand, medication is a C2 if it's classified as highly addictive, things of that nature. The street value on it's high. This is your OxyContin, your Percocet, Percodan, things like that. Dilaudid, all those are C2s. C3s are one that they want them to be short term. They have a chance for addiction, but they're lower on the totem pole as far as addiction rate and as far as basically what they do. They're not as effective as the other medications. And then you have C4, which they're controlled, but they're not controlled. Most pharmacies don't even lock these up because they just have such a low incidence of overdose or they have such a low incidence of people ODing on them or addictiveness and things like that. These would classify like Lamodal. There's some benzos that are low grade that are on there and things of that nature. I think that they still have things like Dalmane, flurazepam, things like that are still on there, but that's kind of what it is. And then everything else falls into class 5 and 6, which are regulated but not really controlled. But in my opinion, it's really senseless for physicians to try to make a spectrum or make a broad across the board, this is what it is, when you really need to look at individual people and see what it is that helps them and what would be too much. She is also in a special situation because she's had a gastric bypass. which is basically they reroute your stomach to where it just becomes a pouch this big to lose weight. The reason she had that is when she was diagnosed with MS, she had an issue where she couldn't walk for a while. And without walking, I mean, she put on quite a bit of weight, and her health was in jeopardy. So they, as far as heart attack, stroke, and things like that because of the weight. So she had that surgery. Now what that does is it means that things aren't absorbed the same way that they would be for a normal person. With the absorption starting in the stomach through the small intestine, it moves through that a lot quicker. So it doesn't get as absorbed, so it takes more of the medication to get the same effect. And with her, this has been proven with blood tests and things like that, of taking the normal doses of things, the levels are not there that normally would be there for medication. So they have to increase it. However, this is something that they're not taking into account as well. People like that, they have to have special needs basically for their illnesses and for the medications that they're on. She talked to the doctor about having a fentanyl patch, even a low dose of that one patch lasts, I think it's 72 hours, and it stays in your bloodstream. And the reply was, well, to do that, we have to cut back on this again. Everything they want to do is cut back, not change a medication, not run this test or check this or do this. She hasn't even had a blood test or a urine sample being on all these medications for, that I know of, 6 months. And it may be longer. I'm not quite sure of that number. And that in itself, which to me tells me they're not trying to manage the pain as a pain management clinic should be doing. So the name of the practice is the Southeastern International Pain Associates, or SIPA. And there's more than one doctor there, but the main doctor that she sees is Dr. Trey Rollins. Now I believe he's an anesthesiologist that does pain management. And his nurse practitioner name is Mary Paris. So they're not necessarily him, but she's the one that's trying to reduce all this medication. And when she sees Dr. Rollins, he doesn't change anything. He keeps it right where it has been and has been working. So hopefully the next visit she sees him, hopefully he'll get things back to the right levels that they were prior to Mary trying to change everything. I don't know if she's doing that to make herself look good, saying, oh, well, I did this and I did this. And she seems like the type that would do something like that to me. Yesterday I made the comment that their personalities don't clash, but they actually do clash. So I'm going, instead of redoing the whole video, I'm going to throw that in here. So that's kind of a error yesterday that I want to clear now. Their personalities do clash, and they just don't get along. So I just wanted to give some feedback as to what went on yesterday, getting through the emotions. And I didn't want everybody to think that I'm just, whining because she was whining about, not getting her medication or whatever, to really show that this is legitimately a necessity for her because of the things. And I didn't even go into detail today about the MS and the lumbar injuries she has and things like that. But just really the main one is the pseudotumor that's causing a lot of the pain. Fibromyalgia, things like that she has to deal with on a daily basis. I just wanted to clarify that and basically talk again, even though my speech is off today. Speaking more actually helps. For now, guys, this is Penguin Speaks. So I'm going to leave you with that. Be somebody important. Be yourself. Peace out.